Continuing on our theme of brain perfusion, our third speaker is Mark Haake, Director of the Research MRI Facilities at Wayne State University. Mark will speak to us on flow quantification in CCSVI by MRI. Mark?
Well, good morning, everyone. It's a pleasure to be back here at this New York meeting again, and also particularly to have the stage set by Robert Zavadinoff and Clive Beggs, who I think have presented two different approaches to some of the things related to blood flow and hemodynamics, and there's a lot of interesting overlap between those presentations that suggests the findings that Robert has may be explainable by some of the hemodynamics and fluid dynamics. And I hope we find that some of the quantitative flow data that I'm going to present today may actually be in agreement with some of the material they presented. So I'll try to pause and comment a little bit on that as I can during these slides. So I do have grants from the NIH, and I do have personal interest in the company Magnetic Resonance Innovations. So I'm going to show you just a little bit here about how we can measure flow in magnetic resonance imaging. So normally, if we're trying to teach something very simplistic about flow in a tube, we might assume we have plug flow. But in fact, we don't have plug flow. Through the vessels, if the vessels are straight enough for long enough, roughly 10 times the length of their diameter, then you'll develop parabolic flow, which means the flow is fastest down the middle and slowest at the edge where they have the greatest resistance. So you get an expression something like the maximum times a function of the distance away from the center. So if the center is a radius, the vessel has a radius a, the formula will be velocity as a function of position in y is the maximum velocity times 1 minus y over a squared. We really don't need that mathematics for this, but it's just nice to have an understanding that at least in a straight vessel, you'll see variations in velocity. It becomes much more complicated if you have bends or twists that Clive was talking about, or if you've pinched it, you can completely change things at a bifurcation. So what does this look like on an MR image? Well, this is an example of what we call a phase image. The image on the right shows stationary tissue with actually blood flowing down the middle of this phantom that we made. But we designed the MR sequence particularly so that this phase is completely compensated independent of the motion of whatever is happening inside. So we call that a fully velocity compensated sequence. So when Robert talks about the SWI sequence, that's fully velocity compensated. So when he looks at phase associated with iron, which really looks very different than this, that's because there's iron present, not because there's a blood flow present. But we can purposely modify the structure of the MR sequence so that we can make it sensitive to the flow. And I think on the left-hand side, you can see quite nicely this parabolic nature to the flow. So the higher up this is, the faster the flow. So here we've designed this so that the intensity of this phase image is directly proportional to the speed at every pixel we're looking at. So in this particular case, we're looking at a coronal cut through a vessel that's running through the magnetic field. Now, most of what I'm going to show you from now on, instead of being collected this way, will be collected transverse instead. So here's an example of a transverse cut through the neck. You can see many vessels here. So you can see arteries, you can see veins. You can see them drawn here. The arteries are drawn in red. So you have the carotid arteries or the vertebral arteries. And all the veins are drawn in blue, and there are a lot of veins coming out. It's really quite amazing how consistent the arterial system is. And I suppose if I were to try to use an analogy, I would say, you just imagine that you have all the water being fed by your city into a city block of houses, and you're all going to get fed the water the same way initially. But what you do with your water is up to you. You can water your garden, you can have a shower on the second floor, you can have a swimming pool. And so how you feed that water out is completely up to you. And in fact, the venous system is very unique to each individual. You can get a huge variety of different vessels playing a major role here. So as you can see, there are many veins draining the blood, but there are basically 4 major arteries feeding this. And later on, I'm going to show you an evaluation over 250 people and giving you some example distributions of actual blood flows on the arterial side and the venous side. So in this particular individual, we then take a picture throughout the cardiac cycle. So we cardiac gate this. We can't actually collect it in one rapid acquisition like CT does. So instead, if we have to take the picture 128 times, we gate to the heart 128 times. But each time we do that, we have the potential to collect a resolution of 0.5 millimeter by 0.5 millimeter in plane. So that as long as that heartbeat is regular, consistent, periodic, then that means every time I try to make that measurement and then integrate things together to create that 2D picture, I will have a fairly consistent result. And luckily that is realistically true. We can do this, and we've done it for 25 years. So I'm getting an image here roughly every 40 milliseconds. So every time I take this picture, I get another picture that shows me the blood flow through here, often parabolic on the carotid side. And then we can do the measurements, the area measurements, calculate the average speed in there, and by taking the product of the average speed times the area, we have the flow through that vessel. Now, normally when we do this for MS patients, we actually collect the data in 3 different planes, but to do it, I really only need 1 plane. Probably the most important plane is the one that is just prior to the confluence of the jugulars with the subclavian. And the reason for that is that if the Sundström paper, if I recall correctly, measured blood flow up near C1, C2. But there are many things happening between C1, C2, and T1, T2. There are many vessels that come in, the facial veins and many other veins, the externals, and all these things are changing between C1, C2, and C7, T1. So the best place to make this measurement is down here, not in the upper regions. So here's an example in the bottom left of 4 of the major veins. So we're looking at internal jugular veins, external jugular veins as major veins. And in this individual, this is very similar to Zamboni's criteria. It's not all reflux, but basically for about 1/3 of the cardiac cycle, you can see that in this individual, all 4 of the major veins basically stopped flowing. And in order for the blood to get out of the brain, instead of the average speed being 10 centimeters per second, this had to peak up to 20 centimeters per second, or they wouldn't have got the blood out of the brain in time. So that's a very stressed fluid dynamic system. It's not one where you have nice constant venous flow out. So I want to show you an example of some of the analysis that we do here. So we're plotting in this the time in the cardiac cycle here and the flow in milliliters per second. And you can see here for the carotid arteries in diastole, and then they peak their blood flow up in systole to about 10 milliliters per second. And you have the vertebral arteries here. And here is a left internal jugular vein, which is fairly constant and fairly low for this individual. And here you have the right internal jugular vein, and you can see that he slows down here, which is quite common in this region, just pre-systole, and then peaks up to above 10 milliliters per second, okay? So this is just one example of what you can measure with these type of flows. Now I want you to look carefully right here. Watch that turn black. Now this may not repeat many times, so again, watch that turn black. Same over here. But black means going toward the brain. So the bright white was the internal jugular vein flowing down towards the heart. And all of a sudden, it stopped. And it went backwards. Exactly the reflux that Zamboni was talking about. So the real question is how much reflux is normal and how much is abnormal. I've been a volunteer. I have reflux. I have about 8% reflux. Well, I'm doing okay. I have no white matter lesions and I'm in pretty good shape. So can reflux be normal? Sure, it can be normal. But if you had 30, 40% reflux, that's probably abnormal. So let me show you the velocity, the flow plots for a person like what we just looked at. And here you can see that you have the flow for the venous side as negative 5 milliliters, 10 milliliters per second. It smoothly comes down here during diastole and smoothly goes in the wrong direction and then comes back and increases its speed back towards the heart again with a little delay between systole of the arterial side and the venous side. Of course, there's going to be some delay on the order of, in this case, each of these being 40 milliseconds, maybe 100 millisecond delay on the venous side. So this shows you very nicely what we would call reflux here. But there are times that we will see what we've called the circulatory flow, where in fact we won't see the venous, the integrated venous flow ever going to zero. But if you carefully evaluate the data and look at the positive and negative components of a given jugular vein, you can actually find that there are times when there is, in fact, a negative component. And you will only see that if you go and analyze the data for both positive and negative components. Because when you integrate over the whole vessel, you may not see it. So you can actually get these circulatory patterns where the blood is coming down towards the heart on one side of the jugular and going back up towards the brain on the other side of the jugular. So you can have some very strange effects. Of course, by the valves, when the valves have opened and then are closing, you can get circulatory flow this way too, around the outside of the valves, which is thought to be possibly one source of helping the valves close. So there could be good circulatory flow and bad circulatory flow. But the nice thing about this is you can measure this on every patient. This only takes a few minutes. It's between 1.5 and 3 minutes, depending on the heart rate of the individual. So here's another example. In this case, I want you to look here. You can see a jetting through this fairly large left internal jugular vein. And this may be due to stuck valves, something that Sal had shown me some time ago and kind of giving me the challenge. Could you see that using MR, for example? So the answer is yes, you can. You can very carefully map those out. Now, I really don't have much more for you in terms of what the future is for four-dimensional imaging in one slide at the moment, but we have begun evaluating some software that Siemens has made available and another group with Michael Markle from Freiburg, and this is the four-dimensional imaging. All this means is that when I do my 2D slice, it has 2 dimensions in space, 1 dimension in time. Now we could do 3 dimensions in space and 1 dimension in time. So it's really 3D, 1D. So the advantage would be that instead of just looking at a single slice, for those people who like to do computational fluid dynamics, we would be able to get a complete map of all the streamlines in every vessel, every major vessel. And these are examples of the streamlines that are being mapped out here. So as you can see, the resolution here is not good enough. This method is used now in the aortic arch. We would like to extend that method to be able to study the vessels in the neck, so you can really look at the fluid dynamics of this. So I think that's the future, and that will be an exciting area to look at. So I want to go back to these 2D measurements here and show you an interesting case. Again, we can see that the bright here means flow towards the heart for the vein, and the artery's dark here and dark here, but in this particular case, it's not, it's bright. This individual probably has a blockage of the left subclavian vein, and Don Ponick was telling me that that's not uncommon, but it's interesting that that's also occurring in this MS case, because you can see that there are severe structural abnormalities here. Now you can see lots of veins. And I want to point this out to you here and in a number of other cases. There are many times you can see lots of veins, and trying to come to conclusions from structure alone is very difficult. But if you use the flow information, you can see here that there's basically only one dominant vein. And we see this a lot in MS cases. We have not seen this a lot in normals. We've only done on the order of 20 normals at this point. But this has the potential, I would assume, of being a high-risk issue for multiple sclerosis patients. With only one functioning vein, if you compress that vein, you're at risk, even if it's only for a minute or for 5 minutes. Now, there was an early study done years ago in craniectomies showing that those people who had one dominant vein with more than 3-to-1 ratio of flow were the people who developed stroke, hypoxia, cognitive problems after the surgery. Now, you know, we're talking years and years of effects going on in MS. However, you're relying on a single vessel to drain most of the blood from the brain. And here you can see the red line that's above 0. That actually represents the flow in the wrong direction of the vertebral artery in this particular individual. So again, you can map out all of this information and get a very good understanding of what you have. Now, for the interventional radiologist, of course, you also have the complete 3D structure, so you can get an idea of what you're going to be looking at before you go in there. Because you're going in, you're injecting, you're looking at one side at a time. Here you have the information available to you ahead of time for preoperative planning. Now, here's an example of again, a 2D time of flight. This is a very interesting variation. Here we can see that there's not really a significant transverse sinus available, and this vessel, which is usually not very big, which is the inferior petrosal sinus, is the major draining vein into the internal jugular vein. So it doesn't have the normal transverse sinus, sigmoid sinus, internal jugular vein. It has this interesting abnormality. Okay, well, this looks pretty normal, right? I mean, it's not too bad otherwise. If I wasn't looking at the upper part of the brain, you might say, okay, he's normal. Well, let's look at the flow. This person is another dramatic example of a person dominated by one jugular. Those other vessels, I see them because I used a contrast agent. Blood flows through them very slowly. If a radiologist had looked at this picture, what could he have said is abnormal? Nothing, except that structural abnormality. So the flow gives you the functional information. The flow is probably one of the most critical pieces of information, not only to tell you that there's something wrong and feed into the data that Robert showed and Clive showed, but also for you as an interventionalist to decide, should you really treat this person or not? And I'll come and give you another example of this in a moment. But I want to show you that here's the vein that actually is fed by the petrosal sinus. It has positive flow, negative flow, positive flow. And that means that you're going to have that same reflux in the petrosal sinus. And now what's the petrosal sinus draining? Many of the small vessels in the interior of the brain. So if you have this backwards flow, it's exactly what Paolo Zamboni has said using ultrasound, that he can see reflux in the petrosal sinus. He can see reflux in the ophthalmic veins. Now, we haven't measured that in the past, but in practice, we could go in and try to do that. Here, we would need even higher resolution. We use 1/2 by 1/2 millimeter just to do the internal jugular veins. We would probably have to push that to 1/4 by 1/4 or something to do a good job on the petrosal sinus. But may be possible to do that. So again, here's this characteristic single vessel draining the brain. Here's another case like that. Again, there's lots of vessels here. The vertebral vessels are well developed. The title of this slide is "To Treat or Not to Treat." Now, this individual happens to have been treated. This individual has 2 healthy jugulars. How do I know that? Because if I look at the flow, they both have almost the same flow. The circles are the left internal jugular vein, and the triangles at the bottom here, the negative, the blue, are the right internal jugular vein. They peak up to between 4 and 6 milliliters per second, giving 10 milliliters per second total, not counting the other veins. They're in good shape. This person was treated. This person now has an occluded jugular vein. Why did you treat this person? I think we need to do what they do with carotid atherosclerosis today. It used to be that if you had 70% or greater stenosis, do an endarterectomy, do a stent, do something. But not today. Today, people look to see if the potential of a vulnerable plaque is the critical issue. Will that plaque be dislodged and create an emboli that will lead to stroke? If the risk of that is not there, they're not going to do that endarterectomy today. So they've got a little bit smarter here. It's not just stenosis that's critical. It's the blood flow that's critical, and it's the status of the plaque that's critical. So if we go back and ask, I don't care if you think there are bad valves here, because the flow is normal here. So should you have treated this person? So I think this is a very serious issue. To me, I'm not a radiologist, and I'm not a neurologist, and I'm not an interventional radiologist. But it's pretty upsetting if I get emails from people telling me, look, I had normal flow before I got treated. I don't have normal flow anymore. Those people are going to get worse. So I think we're at the stage today we need to take advantage of quantifying this data before you make a decision that you're going to treat valves or you're going to treat this vessel. So now I want to go back and show something that I think has some very similar parallels to what Robert showed on the perfusion, where he split this up into normal-looking MS patients and abnormal-looking patients and found that the normals had high flow and the abnormals had low flow comparing to CCSVI. So we did something similar to that where we started looking at the abnormal structures that we saw and then looked at the flow patterns for the people who had, the MS people who had abnormal structures to the MS group that had normal structures. So I'm going to show you some results here, and I really enjoy referring to Dup's 2004 paper because we're going to take advantage of the fact that he's an acknowledged expert in ultrasound. And he points out that in this paper, he did 50 normals, and he said, you know, the old adage that the jugulars carry most of the blood flow from your brain is right. He said 72% of people have more than 2/3 of the blood taken out of the brain by the internal jugular veins. And in the middle third, only 22%, and only 6% have less than 1/3 of the blood flow carried out by the jugulars. So what we did is we split these populations up, and we looked at 2 different sites, a total of 200 cases, and we looked at those who had basically no visible stenosis on the MR and those who had visible stenosis on the MR. And we mapped out the percentage of type 1, type 2, type 3. And lo and behold, we found 70% of those people who had no clear abnormalities have more than 2/3 of the blood flow carried by the jugulars. Well, thank you, Dr. Dup. It's very nice to have your work, and it's very nice to demonstrate that we could do this with MR as well. Now let's look at the other group of people. Okay, and here you can see that from one site it's 80 out of 100 and the other site 56 out of 100. And now you can see a clear drop from type 1 from 72 to 44 to 28. So in this large distribution of MS patients, you can see that they have clearly abnormally low flow in the internal jugular veins. And I can't quote a p-value for this because the numbers are so high here and the statistics are so great that this is just a clear difference. And look what happens in type 3, from 6% to 12% to 16%. So this is definite quantitative evidence of abnormal flow for multiple sclerosis patients. I don't want to spend too much time on this, but in this plot, I took a scattergram, and we've plotted the flow in the dominant jugular vein and then the flow in the subdominant jugular vein. So this line is the line of identity when they're both equal, and the solids represent those MS patients who had structural abnormalities. So let's look at how that correlates with flow. If we look at constant flow of 8 milliliters per second or less, you can see almost every one of these people in the bottom left here are solid. They have structural abnormalities. If we look at the subdominant flow being less than 3 milliliters per second, again, almost all of these are solid. And if we look at that ratio from the craniectomy study that said it may be dangerous if you have more than 3-to-1 ratio of dominant to subdominant flow, and that's this purple here, and again, they're almost all solid, that those are the areas of highest risk. So here you have a very nice data set that shows in all of those risk factors, those are the ones that likely have structural abnormalities. So I'm just going to show you one or two tables here, and I'm not going to go over every example, but I want to show you that sometimes in different sites using different flow quantifications, using GE versus Siemens, for example, depending on the cardiac gating you do, whether you use pulse triggering or cardiac gating, you might be wrong by 10%, or I might be wrong by 10%, or let's just say we're different by 10%. And here is an example from these 125 cases from each site. And I'm just going to take the right internal jugular vein. Here, I get a flow of minus 6.35 milliliters per second. On here, I get 4.9. On the total left arterial flow, I get 8 milliliters per second. Here, I only get 7. I'm wrong by about 10%. In fact, it's consistently lower by 10% at the other site. So what people in ultrasound do, and what Dup did, was he normalized the venous flow to the total arterial flow. Well, that's a very nice idea, because that means as long as your flow measurements are consistent, even if you're wrong by a scale factor, you should get the same answers once you normalize that data. So this is a very robust way to do that. So let's go back and look here at the total right arterial flow for the total arterial flow. 49.72 at site 1, 50.00 at site 2. On the left, 50.28, 50.00. So you can see, thank you very much. You can see much better now. You can see much better the equality between these two sites. In fact, it's impressively so. The arterial system is incredibly constant from site to site here. You can also see the famous ratio here that the overall flow in the left is about 60% of that, on average, of that in the right internal jugular vein. That's not always true. I happen to be left dominant, not right dominant, but that's just an average over all these 250 people. So we can also go and do cross-sectional area measurements for these. And I'm just going to show you one example here on the right internal jugular vein. It's 75 millimeters squared. Well, remember the definition of area is pi r squared. And so if I take pi to be 3 to make life easy, 75 divided by 3 is 25. Square root of 25 is 5. So the radius is 5. The diameter is 10. So the average diameter of that right internal jugular vein is 1 centimeter. Now, as Robert pointed out, these diameters vary all over the place. So rather than calling this a percent stenosis, although in a paper we hope that will be accepted shortly, we used 67% stenosis that in this case was based on a 1 centimeter diameter as the correct value. So rather than quoting it as stenosis, we can just simply say if the area is less than 25 millimeters squared in the lower C6, C7 area, we'll call it stenotic. If it's less than 12.5 up at C1, C2, we'll call it stenotic. Why? Because the average size of the vessel in that area is much smaller than it is down around C7, T1. So now we have lots of data here. We have the histograms associated with all this data. We have some good information. So the question is how else can we compare this flow data with what we have? Now we've done over 1,000 cases so far, but we haven't processed any flare data until recently. We've just started doing that. We've only done about 25 or 30 cases right now. What you would like to do is you'd like to quantify how much of these white matter abnormalities are present. You'd like to break it up into periventricular regions and deep white matter lesions. And what I'd like to do is to be able to plot the lesion load versus the flow. So this is our first attempt to do that. It's only with about 30 people. Here's the total internal jugular flow rate in milliliters per second. And you can see there's not really much correlation in this area, although it's kind of interesting for at least this very small number of cases that when the flow is very low, we can have some fairly high lesion loads associated with this. So I know, Robert, maybe you've found something like this before, but I'm hoping by the time February comes, we'll have done several hundred cases like this, and we'll be able to show whether or not the flow correlates with lesion load. Well, that would be very nice if that's the case. That's starting to give us a much stronger correlation. And there are not a lot of correlations like this, where in MR you correlate lesion load with EDSS or other things, and it often doesn't work. So it would be nice if it's true for CCSVI. We can also do CSF flows. So here's an example over, I think, about 51 cases, or no, 42 cases in this case. And we can see that the flow for the CSF that's flowing towards the brain is about 2 milliliters per second, and that takes up about 60% of the total cardiac cycle. So 2 times 60 is 120. What do you expect the flow to be going down afterwards if it's only 40%? 3 times 40 is 120, and sure enough, it's 3 milliliters per second. So you can get a lot of information just from the histograms here, but we want to look at an actual profile in a moment. And here's the average ratio. It's about 40%. This matches the work of Balladant in 2001. He has a much broader distribution than we did, 40 plus or minus 10. This is more like 40 plus or minus 5, but it's still in very good agreement with his data. So what do these look like? Now we can look at all the flow components together. Here's the arterial flow in diastole peaking into systole. Here's the CSF flow in a normal, and it peaks up to about 2. It crosses through here just about the beginning of systole, peaks down to about 3. And here's the venous side here, which looks okay. It's fairly normal. So a very nice example of this. And here's an abnormal case of CSF flow. And here you can see it's now at 4 milliliters per second, peaking down to minus 8 milliliters per second. This is highly abnormal. It doesn't approach most of the other examples that are there. So I'm finished in 2 slides, Sal. So again, I want to point out here why it's important that patients have MR scans. If I were a neurologist, I would say, I want this to monitor the lesions and other physical or anatomical abnormalities. I'm interested also in the iron content. I want to monitor the arterial, venous, and CSF flow changes, actually the flow itself before and after. Why? Because if there's normal flow in the IJVs, maybe you don't want to treat these people. You want to use the 3D vascular data to plan your intervention. And beware, there are many complicated situations where you can get in there and it's so complicated, there's probably nothing you can do. What really concerns me are the cases of truncular venous malformation, where you have a sigmoid sinus that comes off to the side and dead ends. And the jugular is reconstituted by the vertebral vessels. So in fact, that reconstituted jugular often has stenosis associated with it. But it's not playing a big role here because you have multiple collaterals in that case. Can you really treat that person? And then there are other cases that are so complicated where you have the internal jugular vein merging into the external jugular vein. Should you be doing anything? I think you need, as interventionalists, to be planning this ahead of time before you go in to do this. Do you have the tools to do it? You clearly do. You could use CT. You can use MR. CT won't give you flow, however. And hopefully, in all the work that's done in these first 3 talks, we hope to characterize the different types of MS populations by having this quantitative data. And of course, for the patient, this is a baseline scan for them. If they develop restenosis and you've not had an MR scan for them, what are they going to compare to? They have nothing to compare to. So in summary, I think we need to better understand the hemodynamics and fluid dynamics. Patients need to be imaged before and after. We should be creating an international database associated with this. And at the ISNVD in February this year, we're going to have 3 consensus panels on ultrasound, MR, and on interventional treatment. So we'll be dealing with that, and we'll need to do a lot of work before February to be prepared for that. So we welcome participation from any of you who may be interested in getting involved. I think we also need to do something that's been missed. The only person I can say here, and it's wonderful to have Robert here, who's really made a crack at doing normals, and hundreds of normals, is the work that's going on in Buffalo. But I'm proposing now that many of you should be doing normals also. And we have an application we're putting together. I call it the Millennium Project, to do 1,000 normals with all of this technology I've shown you today. You absolutely have to have normals. And finally, if you have any questions, please visit ms-mri.com for any updates on this. And thank you very much. And Sal, I'm sorry if I took a little longer than I should have.